Hello, everyone, and thank you for joining us and our partners at Belay Health Solutions for today's training, Practical Strategies to Make the Transition from Fee-for-Service to Value-Based Care. My name is Rick Brown, and I am ACU Senior Director of Communications, Membership, and Special Initiatives. I and my colleague, Jen Dix, our Communications and Membership Coordinator, will be your hosts for today's training. If you have any technical issues during today's webinar, please reach out to me or my colleague, Jen, for help. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust, multifaceted workforce to help transform communities to increase access to quality care for all. We do that by providing advocacy, professional education, training and technical assistance, and more. We invite you to learn more about us and membership with ACU at clinicians.org. Lastly, before we begin, I just wanted to go over a few quick housekeeping items. First, we will be recording this session, and we'll send you the recording and the slides a short time after the webinar. We also encourage you to ask questions via the chat during the Q&A section at the conclusion. As our training concludes as well, please make sure to complete our evaluation. It's tremendously useful to help us continue to improve the quality of our presentations. And with that, I am pleased to turn things over to our Executive Director, Amanda Pierce-Kelly, to help kick us off.
Hey everybody, morning or afternoon, depending on where you're joining us from. It's great to see you and thank you so much for taking the time. I know it's a really busy time always, but especially at the moment. My name is Amanda Pierce-Kelly. As Rick said, I'm the Executive Director here at ACU. And I'm really excited about the conversation today. I'm very happy to connect you guys with Scott and Andrea at Belay. Belay is our preferred partner, our exclusive partner in the space for value-based care and contracting. What has always struck me about the partnership and the work with Belay is that they don't just talk the talk, they walk the walk. I think I would say in terms of partnership and in understanding health centers. Both of them have an incredibly rich history working with health centers, but also in this space. But I will also call out Dr. Scott Early as a former CMO at a health center. And so what I was so struck by when I talked to Scott early on was that he has very much firsthand experience as a provider, but also as a chief administrator in terms of how value-based care and contracting should work to benefit not just the organization, but to help drive mission and frankly, providers as well. There's just so many benefits here. I also just want to acknowledge that, this is a topic where everybody is in a different place in their journey with value-based care and value-based contracting. There's not an easy solution. If there was, then we would have had this, wrapped up and figured out more than a decade ago. But I think the models that are out there and partners like Belay are so incredibly valuable to helping to identify where the solutions exist and how they can be supportive. And I think I would just also say that it's okay to not have all the answers. It's okay to not know every single detail. I myself am learning things about this topic continually each and every day, right down to, which I thought I knew that acronym, but I don't, or I thought I understood that model, but there's some nuance to it. So I know that Andrea is going to get into that and Dr. Early will as well. But let me do a quick introduction and then turn it over to them because there's a lot of really great information to share. And I hope that there will be some time for some conversation and some questions at the end. So Dr. Scott Early is an innovative clinical thought leader. He is the co-founder and president of Belay. He's passionate about improving primary care for patients and providers, and he served for 17 years as the founding director of the Lawrence Family Medicine Residency Program. He's nationally recognized that's a nationally recognized program for the innovation, just in terms of what he built at Lawrence Family. He also spent 5 years as the chief medical officer at that FQHC. In 2015, he founded Kronos Health, a Lawrence, Massachusetts-based medical practice delivering patient-centered care in a dramatically higher touch, higher impact primary care model where providers spend over 30 minutes per visit with patients on average. I think, again, what I love about Scott is that he's able to look through the lens of what it is to be a practicing provider and to want to spend time with patients, but also to bridge that with what it looks like from a business perspective to be able to further mission and operations. We are also joined by Andrea Osborne. Andrea is an accomplished healthcare executive with over 20 years of experience in value-based care, post-acute care, and business development. She is on Belay's Chief Operating Officer. Previously, she served as a Senior Vice President of ACU Operations and Delegated Services at Village MD, where she oversaw Medicare programs for over 150,000 full risk lives. She also launched new accountable care organizations and developed narrow networks. Under her leadership, she achieved top performance in CMS models and earned NACO's Quality Award in 2020. So as I said, we are joined by two incredible experts, and I'm really pleased to turn things right over to them. I think that Andrea is going to go first. Do I have that right?
I think I'm going to go first, and then Andrea.
Okay,
But
great.
thank you, Amanda, Rick, and Jen. I really appreciate the very kind introduction. And as I think Amanda has heard me say before, I'm never happier than when I'm talking to folks from community health centers. That's where my real heart lies. So we practice this ahead of time. So hopefully this is going to work. I'm going to share my screen. And then I'm going to go here. And then, all right, I'm assuming everyone can see this.
You might have to try again.
Yeah. Okay, perfect. Okay, so we already did the introduction.
It hasn't come through yet for whatever reason.
Oh.
This is always the trick with technology.
Yeah,
here we go. It looks like it's coming through right now.
All right. Yeah, that was all my mistake as usual. All right. And then now let's, okay. I think you can all see this, the first slide. Perfect. Thank you. Okay. So we did introductions. So we'll blow past that. Some people ask us like what on belay, what does that mean? If you're done any climbing, it's a mountain climbing reference. And we think of value-based care, it's sort of like climbing a mountain. You've got to be prepared. You've got to be careful on the journey. And when you get to the top, there's a great view. So our job at On Belay is to help practices and community health centers climb the mountain of value-based care and get there safely and be able to enjoy the view and the rewards. Today's session, we're going to, sort of try to give an overview. My guess is that some folks on the call already know a lot about value-based care and some, maybe not so much. So we're going to do an overview. We're going to talk about some of the new models. And we're going to help, we're going to really try to focus on practical suggestions for getting started and succeeding. So, I suspect everybody knows most of this, out of now, coming up on $5 trillion we spend as a country on healthcare. We waste about 40% of it. As folks in community health centers know better than anyone else, health disparities both cost money and cause harm to people. Primary care, although often listed and cited as like, the cure to many of the healthcare ills in the United States, primary care only gets 6%. In Medicare, it's really probably closer to 4%. And you all know very well that workforce issues are going from bad to worse. Unfortunately, this is how I think a lot of patients feel. They wait forever to get somebody on the phone and then to get an appointment, and then they get to the office and they wait longer. And this would be a funny cartoon if it weren't true. Please don't waste the doctor's time with questions. Hamster healthcare, that was actually a term coined in an article in the British Medical Journal over 20 years ago. And even then it talked about how, primary care providers especially were running faster and faster and getting nowhere. I, often when talking to primary care providers, I refer to a day in their life as running from room to room, and they all know what I'm talking about. So, what's the root of the problem? Well, there's not one thing, but certainly there are misaligned incentives. There's definitely, in most settings, not enough time and not enough other resources. This is a team effort. Community health center folks know that very well. On average, because the average primary care provider has, about 1,500 patients, maybe in health centers slightly lower than that, but you do the math and it's 60 minutes or less of face time per patient per year. And if you're a, 25 or 30-year-old healthy person, that might even be more than enough. But if you're not 25 or 30 or not very healthy, like many of our older patients, 60 minutes is often what you need every single visit. Our system is also quite fragmented. And until now, until value-based care, I think, really began picking up steam, there were not lots of incentives for providing preventive care and keeping people healthy. The incentive was visits. And as a health center leader, I grew very tired very quickly of counting visits per hour. And I look forward to the day when in primary care, we don't even have to think about visits per hour. We just have to think about how do we deliver care most effectively and efficiently. So health centers have additional problems. You already work on thin margins. You rely on grants to do a lot of just basic work. We have real difficulties recruiting and retaining staff. And who knows what's coming down the pike with, the new administration in terms of Medicaid and Medicare funding. And depending on what state you're in, some Medicaids are even worse than others in terms of Medicaid reimbursement. And then, we now, I think, maybe through some of the worst of Medicaid eligibility issues coming out of COVID, but that remains a problem for a lot of us. So, Medicare, CMS, has a stated goal, which I believe they are still committed to, of having all Medicare patients in a value-based relationship by 2030. And, that's coming up quick. So whether we like it or not, as providers and as health centers, we are moving towards value-based care. We're moving away from fee-for-service. Again, I think that's a good thing. But it's coming, and so let's be ready, and let's do it well and take advantage of the benefits that it offers. So, value-based care, I mean, I really think of it, if I had to really sum it up, it is going from being reactive to being proactive. In some models, there's now a move towards capitation. I think a lot of folks have some misconceptions about that, and we'll talk about that a little bit later. Value-based care also allows us to really invest in primary care and in primary care teams. And if we do it well, and as we gain experience, we end up with resources to give primary care teams the time to actually do a good job and take care of patients the way that they've always wanted to. So, what's in it for health centers as organizations? I think that it does allow you to direct resources towards keeping people healthy and not just responding to acute illnesses and acute problems. I think you all know that the resources to really address disparities, those are hard to come by if you are running from room to room and getting paid fee for service. And the revenue in value-based care, when there are shared savings, that shared savings can end up being multiples of what you can realize in a fee-for-service world. And that ends up being better care, and providers end up being happier. Providers and all of us in healthcare, we have different motivations, but I think most providers and the primary care team, what do they want most? they want to go home at the end of the day feeling like they did a good job. I mean, Deming used to call that pride of workmanship. And so I think that in value-based care, we will have an opportunity to let the primary care team go home at the end of the day feeling like they did what their patients need, provided them the care they needed. And as we talked about a little bit earlier, Medicare clearly is moving towards value-based care. I'm in Massachusetts, and Medicaid is almost wholly in value-based fee arrangements, and many states are moving towards that as well. This is sort of the other side of the coin. Why is it, not just good for health centers, but good for patients? It's the same stuff. Better health outcomes, smaller panels for PCP. That will ultimately allow us to improve access to care, even if we spend more time with people. If we can more easily recruit and retain providers, we'll improve access. And what do health centers need, among other things? It's a strong financial foundation, and value-based care, if done well, can build that foundation. Okay, so shared savings. It's actually fairly simple. It's economics 101. It's income minus expenses. So how is the income determined? It's also referred to as the benchmark. Amanda, you referred to all the acronyms in healthcare and in value-based care. And boy, before I was at Belay, I had never really heard of benchmark. But that's the budget, I think, is almost a better word. And the budget that Medicare sets for each patient, or the estimate of what they think a patient will cost, is based on demographics. So, age and sex, and where does the person live? And then it's also based on the complexity of the patients. And as many of you know, that's related to the risk adjustment factor. And that's determined by the diagnoses attached to a bill submitted to Medicare from the year before. And some diagnoses, don't impact the risk score at all, and others have quite a large impact. One of the things to keep in mind is that the average diagnosis that impacts the risk score has a value in value-based care of $2,500 to $3,000. So, when you're entering into a value-based contract, you've got to make sure that you have the revenue coming in, the budget, if you will, to provide care. And health centers certainly have very complicated patients. The only way Medicare and other payers know that is doing appropriate risk adjustment. I'm also going to just one more comment about risk adjustment. I was a CMO at a health center. The last thing providers wanted me to announce was that we were having yet another, noon conference on risk adjustment, where we would try to teach them to be experts. At Belay, we actually think that's sort of a failed strategy. And we try to provide a lot of support. Ultimately, we need the providers to work with us, but we are not trying to make them experts in risk adjustment. We're trying to do some of the heavy lifting and tee it up for them so that they can spend most of their time doing what they are good at, and that is caring for patients. So the expenses, the other side of the equation, it's basically everything Medicare spends money on. There are a few little exceptions, but every time Medicare pays a hospital, an emergency room, a specialist pays for medication, DME, home health care, et cetera, that comes out of the benchmark. So how do you generate shared savings? Well, you optimize revenue through risk adjustment. You keep patients healthy. And generally, if you keep them healthy, that means they don't need to go to the emergency room as much. They don't get hospitalized, for preventable problems. And that saves money. And as one of Andrea's and my colleagues, Dr. Bob Lenegro, often says, I'm going to give him credit, prevent the preventable. That's what we're trying to do. And if you prevent the preventable, you'll generate shared savings, and your patients will be grateful. Expectations and assumptions about value-based care. Again, I'm going to try to quickly go through this. In fee-for-service, you're treating disease, and value-based care, you're trying to prevent as much as possible. You're also going to manage acute problems. You want to avoid that Friday afternoon phone call from the patient with congestive heart failure, and where they say, "Doc, my feet are swollen and I'm short of breath." And you say, "Go to the emergency room." when you're in a value-based system and you have resources for care management, you can have a member of the team calling those patients periodically, so you never get to the point, or rarely get to the point, where you have to send them to the emergency department. So revenue, fee for service, it's volume driven, it's visits per hour. If you're a specialist or a proceduralist, it's how many procedures you do. In value-based care, in many programs, there is capitation, there's shared savings, and it's really outcomes driven. You get rewarded financially by keeping patients healthy, giving them all the care they need and not wasting resources. It's in fee for service, it's reactive. We talked about this already, rather than proactive. You're not trying to maximize visits per hour. In value-based care, you have a team of people, nurse, and it's the whole team. It's the provider, it's the receptionist, it's the medical assistant, the nurse care manager. Typically in fee for service, most of what you do is in the office or clinic. And in value-based care, it's where can you best provide care? In some cases, that is in the office in an exam room. Other times it's a phone call. Other times it's doing home visits. Other times it's doing, community-based interventions. So what to expect? One of my favorite sayings about value-based care, and this actually comes from Rashika Fernandopoulos, one of the founders of IORA, there's no free lunch. And then I paraphrase Dr. Fernandopoulos' comment by saying, you don't get paid more to provide the same old crappy care. Shared savings is when you provide better care. So there is a learning curve. We're not going to flip on a switch, and you're not going to go from fee for service to value-based care overnight. There are differences. There's learning to be done. I think, learning can also be fun. And to the point or to the extent it allows you to actually focus more on what's important, it makes a difference for everybody. So, what are some of the building blocks? Another lesson that we've learned on Belay, well, we started knowing that, and one of our motivations was knowing that primary care providers and teams are completely overwhelmed. Their plates are full. They are running from room to room. So before we add anything new to their plates, we try to take something off. Practices often, in their current situation, don't have enough information. They have what's in their EHR. In value-based care, we have access to claims data. We can dip into the EHR. We have a bunch of tools. We have what's called ADT feeds, admission discharge transfer feeds. So we know almost immediately when someone ends up in the emergency room. So we try to provide more information. Risk stratification is really important. None of you will be surprised that, there's a relatively small percentage of patients who are consuming a lot of healthcare resources. And that's often because we're not actually being proactive. So you need to know who your complicated patients are. When we show a practice, let's say, their top 10 most complicated patients, a typical response is, we recognize 8 or 9 of those folks, but 1 or 2 of them, we don't know who they are. They're not even in a record. Somehow they are aligned to that practice. Some insurance carrier thinks you're the PCP. So you need to know who your patients are and who the complicated ones are. I've already talked ad nauseum about being proactive rather than reactive. Access, for health centers, one of the things that you do most importantly is provide access to underserved communities. I think in value-based care, that's both a benefit, and it's also a key. So, when a patient calls on a, Friday, you want to be able to say, rather than go to the emergency room, come on in, we'll see you. So you want to build capacity to see patients at off hours, whether it's evenings, weekends, whatever. Access to patients is really important. Care management, I think health centers actually know more about care management than the average private practice. You often have nurse care managers and others managing some of your high-risk patients. It's really critical in value-based care. Integrated behavioral health, some health centers, really I learned a lot about integrating behavioral health in my time at Lynn Community Health Center, where we were fortunate to have a 1-to-1 ratio between primary care medical providers and behavioral health providers. It makes an enormous difference. So if you're not integrating with behavioral health, I think this is one of the things to try to work towards. And I talked already about accurate risk adjustment and coding. So getting started. So one of the important things is to actually make a decision to get started. It's really easy, sometimes to say, well, we're not quite ready and we need some more planning and, maybe next year, maybe whenever. Make a commitment to get started because 2030 is coming. Medicaid programs are moving towards it, so that, and there is, as we said, a learning curve. So get started. You want to ahead of time decide how are you going to determine whether you're being effective. So you want to identify key performance indicators, and certainly I would start with the clinical ones, but you also need to include financial and utilization ones. On Belay, we help provide some of that information for you. You've heard me now harp on risk adjustment and care management. Those are really key initial things. When we work with practices, we connect into their EHR, and we have a population health platform. And you want to communicate with stakeholders, and that's a broad group. So that's your current staff, leadership, and all of the the line staff at the health center. Your board of directors needs to be involved early on in the discussion. Other organizations you work with in the community. So you want to make sure everyone knows what you're doing and why you're doing it. Then once you get going, so you develop some KPIs, you got to keep track of them, and that's another thing that I think that we help do, and celebrate successes. That's really because we don't want you to work harder, but you're going to be doing some things differently. So when you have some success, make sure people get credit. Risk adjustment never ends. I wish it did. It doesn't. Every year you got to start over again. And again, communicate with stakeholders. One of my favorite sayings about communication is, if you want it to be effective, you have to communicate 7 times in 7 ways. And now I'm going to turn it over to my colleague, Andrea. And you can just tell me when to advance the slides, because I think I'm still in control of that.
Yep. Thank you, Scott. So to tell you a little bit about the variety of ways to join value-based care, this is kind of a stair step of what risk looks like. And so what we saw early on in ACOs is some pay for performance, paying if you did well on certain quality metrics. You might be familiar with this in a Medicare Advantage program, where you can earn additional payments for having high quality by meeting high quality metrics. These typically are optional and are usually a first step into entering value-based care. CMS then launched bundled payments, which was how well do you manage a certain condition or surgery. Bundled payments, some were optional, you could choose to do them. Some hospitals were forced into bundles, so there were mandatory payments. So for example, there could be a bundle where CMS said, and we saw this for joint replacements, where you get a certain amount of money. And again, that's more for a health system, but what they did was they said you get a certain amount of money for a joint, and that amount of money has to cover the total spend for that patient for 30, 60, or 90 days. What I want you to know about bundles is we're starting to see those more for conditions, and that you could be seeing some of those patients. There is a new bundle launching in January of 2026 for a significant number of hospitals across the United States. It's called the TEAMS model, and it's focused on 6 conditions where hospitals have to participate, and they'll be given a flat amount of money based on the amount of spend for that condition in the region where they're at. So CMS works with both voluntary models as well as mandatory models. From there are where we actually have accountable care organizations, or where Scott and I and On Belay work, which are in ACOs. And again, we have a stair-step risk approach. So the Medicare Shared Savings Program, which is the oldest program, has, and I apologize, you can't see the full title there, but tracks A and B are going to be upside only, so that as you're starting to look at risk, you don't have any of that downside. When Scott was talking about the acuity level of patients and how a patient is appropriately risk scored, the burden of illness for a patient is looked at the year before. So the coding you're doing now on your claims, where you are telling both a payer or the government or Medicare, the illness burden of a patient, that determines next year's rate for that patient. So you're almost always a year behind with risk score coding. So what you do now will help to determine the rate of reimbursement next year on patients. At Belay, because currently all of our practices do have some historic experience with risk, we're currently operating two enhanced ACOs for MSSP. So those are where we have the opportunity to earn 75% of the money we save the government and have the risk of 40% downside. So in the event that our practices do not perform better than they historically were expected, we actually would owe CMS 40% of that back. We also operate an ACO REACH, which is a pilot program that ends at the end of 2026. And the ACO REACH is a 100% upside and downside. So we have full responsibility for all Medicare dollars spent on those patients. There was a great question that came into the Q&A that talked about some of the changes with current leadership. And there was an article, I believe it was this morning in Modern Health Care, where some of the definitions around Medicare Advantage and their vision for the future were changed. And what we saw was the removal of some of the social determinants of health and health equity portions of that vision statement. And I think that is really not a change in the direction of Medicare Advantage fully and how it operates, but actually a change in presidential leadership that we're seeing. We're seeing removal of that from a number of different plans. There also was a termination of another pilot program called the VBID, which again was a Medicare Advantage program. VBID was actually ended under President Biden. VBID actually cost Medicare more money. So as we get to the next slide here, one of the things we'll be talking about is the difference between a model and a program. One is a testing ground, and anything that they're testing, such as bundled payments or ACO REACH, have to show a reduction to Medicare spend in order to continue to operate. And anytime there is not a reduction, the government has to end that program. So I don't think that that is an indication of value-based care going away. We know that the Medicare Trust Fund will run out of money if we stay on fee-for-service. Therefore, it cannot be the model of the future because it is simply unsustainable. And value-based care is there to say, how do we provide better care at less money? So I think value-based care is here to stay. It could change names, but you're going to see programs come and go because we're still testing what works. On the next page, I want to show you what the timelines look like. So as we think about 2026, CMS just released timelines on Friday. So if you are considering joining an ACO next year, the first round of those rosters open May 29th, and you have the ability to join an ACO through August 1st, whether it be ACO REACH or an MSSP. You have until August 1st. CMS opens a window, then they do a check, then they close it, then they open the second window. You don't have to be on a roster by June 12th, that first window. It is helpful though to kind of see what comes back, see if there's any overlaps, make sure your contract and everything is in place. I highly encourage you, if you're considering joining an ACO, to be on an MSSP roster by June 12th, but you technically have until August 1st for both MSSP and REACH. By that August 1st date, you can only be on one ACO roster and you must have a contract in place. CMS will have validated rosters out to all ACOs by October 16th. The REACH dates are technically tentative right now. MSSP has posted their dates. REACH then will reflect them, but because the MSSP dates only came out on Friday, REACH has not had a chance to actually post their dates, but we expect this to be those dates based on what we saw come out from the MSSP ACOs. On the next slide, tell you a little bit about these programs. I mentioned that one is a testing ground. So the Medicare Shared Savings Program, or MSSP, is an actual program. It is a permanent model. It is there by statute and will not go away. It is run by the Centers for Medicare and Medicaid Services, also known by CMS. And as I said, it is a permanent program. In order to make changes to that program, there actually takes an act of Congress to change any of those regulations. It was able to become a permanent program because it had once been a model, and through its testing proved to successfully reduce the overall spend to the Medicare program while improving outcomes for patients. So it is a permanent program. In order to become a permanent program, something first must be a model. The difference with a model is that it's run by the Centers for Medicare and Medicaid Innovation, which sits under CMS, but is a smaller department that became legal under the Affordable Care Act. It is a testing ground. This is where we try different things within the Medicare regulations to see what might work, what reduces cost of care, while also improving outcomes for patients. The VBID program was tested here, found to not be successful, therefore was ended. This program is temporary, so the ACO REACH that I mentioned is currently one of these models. Most models run 5 to 10 years because it does take time to actually see changes from both the provider and the patient and how they work under those programs. One of the things I like about this program is that we do have the ability to change rules without an act of Congress as required in MSSP. But these rules are typically changed by the ACOs coming together, working with the Centers for Medicare and Medicaid Innovation to help explain what is working and what's not working. So one of the things that came out of these models is the Medicare 3-day rule for admission to nursing homes. Under a normal Medicare program, a patient cannot admit to a nursing home and use their Medicare benefit unless they've had 3 midnights in the hospital. We had been testing a nursing home 3-day waiver under these CMMI models. And then when COVID hit, because we knew it worked, we had the rules in place. CMS actually made that a waiver for all Medicare patients. They were quickly able to move over because we'd been testing here. Some of the other testing grounds we have here for waivers are the ability for APPs to do some additional order writing for patients in this program. We have a home health waiver that allows patients to receive home health who are not homebound. And we have a hospice waiver that allows patients to receive hospice while still receiving life-saving measures that are specific to some other areas. And so this is an area where we can go to CMS and say, we feel like this Medicare rule is burdensome, and let me show you examples of why I think we should have a waiver. These waivers come about because we as ACOs advocate for different things that we think would help us provide care to patients. Some of the names you might be used to as models, like I said, are the ACO REACH, the bundles, which were called BPCI, the new team model, which is for hospitals. There is also a new model that launched this year called GUIDE. This is specific for care to patients with dementia that provides care in home to patients who have dementia, as well as a required ability for a 2-week respite stay per year. So again, this is where CMS listens to us as Medicare providers and helps to develop models with us that allow us to provide alternative care that is not currently available under the Medicare program. And here on the next slide, one of the new models that came out this year is a little bit interesting. It is both a model and a program. So what CMS did was they took the Medicare Shared Savings Program chassis, what is approved and under regulation, and they allowed us to put some additional alternatives on top of it. And that is called the ACO Flex model, which just launched this year. One of our Medicare Shared Savings Program is an ACO Flex. And under the ACO Flex, it allows providers to stop receiving fee-for-service payments, but instead to receive a capitation payment. So CMS looks at the Medicare patients that come into a practice. They look at the burden of illness that those patients have. And based on that burden of illness, they set up a capitation rate. And so providers get a predictive amount of money each month, regardless of the number of Medicare patients that come in. Providers also can then still earn shared savings. So in addition to that capitation, if they are able to reduce the overall spend for patients based on what CMS is predicting, providers also get a bonus of shared savings that they help the government save at the end of the year. This is a nice testing ground for providers who want to try capitation, but maybe not at the full risk model of ACO REACH. And on the next slide, some of the keys to success, as Dr. Early talked about, and please feel free, Scott, to join me here on these. But the goal of value-based care is to make life easier and better for you as a care team. One of the great things about the work that you do is that your practices almost always have more than just a physician or a provider. They have a full care team. This allows reimbursement to come in at a capitation level and allows you to provide care that extends beyond the primary care provider. And so that reimbursement of capitation is typically more than what you would get for fee-for-service, which means that those things that you typically can't be reimbursed for, you're now able to start providing, which improves the outcome for the patient and reduces the overall spend for the patient. It allows more appropriate expectations. We know sometimes you need to make phone calls to patients, and those phone calls often you can't be reimbursed for. You have to be able to work with patients and let them know. Our goal now is to move away from sick care and to move towards proactive care. I want to take care of you in a way that keeps you healthy and not just see you with your sick. And that's an expectation that has to be set with both the provider and staff, as well as the patients. When you're telling that patient with a lot of chronic conditions, I want to see you every 2 months, it's helping that patient understand, I want to see you every 2 months because I want to keep you healthy. I want to see those small changes that are happening so we can start to respond to them. Any key in value-based care is always going to be part of risk adjustment. Whether you like it or not, we'd all agree that it is not a perfect system, but CMS currently values your quality outcomes as well as the payment that you receive based on the burden of illness that your patients have. So that requires you as a provider to accurately code the level of sickness a patient has on your claims one time a year so that the government knows how sick your patients are. Every January 1st, all patients are healthy. It's up to you to tell the government how sick your patients are and accurately code that on a claim that is going out. You also have to measure progress. So CMS says we have certain quality metrics we have to achieve. One of the goals for us is to enable you to know how you're progressing. What's the likelihood your patients are going to go to the hospital? How much spend does your patient have? How often are you seeing a patient once they go to the hospital? Are you getting them in within 7 days post-hospital? So in order to be successful in these programs, because CMS is measuring each one of those things, one of our goals is to make sure you know where you stand. You know the admission rate of your patients. You know the readmission rate of your patients. And making sure, again, the last thing, that you're taking a proactive approach to care. By accurately coding your patients, it allows us to stratify your patients and say, here's the patients who are most likely to go to the hospital based on what you've told us about the patients. So we're going to look at the spend of those patients over the past 3 years. We're going to look at the burden of illness that they have and be able to help you stratify those patients for how often they should come in, who you should be reaching out to more, who should be on a care management platform. Scott, anything else you'd like to add here?
No, you did a great job. I think this was sort of meant as just a summary slide, and pretty sure this is the last one. Thank you. And we would be very happy to answer questions.
Thank you so much, you guys. That was such a fantastic presentation. And every time, it doesn't matter how much I feel like I think I know about value-based care. Every time I see a presentation like this, something else comes to the forefront for me. We had a really great question come in, which I'd love for you guys to speak to, just in terms of kind of the environment that we're in and what's happening with CMMI and CMS and Medicare Advantage. And so can you guys speak to that a little bit, just about, okay, where are we and what is the reality in terms of some of the changes? I think, Andrea, this might be a great question for you.
Yeah, I think the reality is the Medicare Trust Fund can't exist on Medicare fee-for-service. It will go bankrupt. And that simply can't happen. And so the CMS and the president and Congress has to find a new way for Medicare to operate, simply put. Whether that becomes Medicare Advantage, whether that becomes one of these value-based programs, I don't think that answer is fully known yet. And I don't think it's a simple answer. I don't think it's an answer that's going to be solved in the next 4 years, because there's tens of millions of patients that have to move. There's systems that have to be set up. To me, the safe way to think about it is, whether you're looking at an MSSP ACO, whether you're in a testing model under CMMI, whether you're in Medicare Advantage, all of these things have some protection and regulation. And so for anything to happen that completely shuts down anything or launches a new program will take an act of Congress, and that is going to take time. To me, I think a safe thing is we all have to be in a little bit of everything. And so we're always going to have some standard Medicare patients. We're also going to be in Medicare Advantage, some because so many Medicaid programs now have their dual eligible, of which you guys see a lot of, which says your dual eligible has to be in a Medicare Advantage program that matches their Medicare service for both Medicare and Medicaid. I think we're all going to have one foot in a little bit of each bucket for right now. But I think by doing that, it allows to say whichever direction this goes, because I don't think that's 100% set yet, you're prepared for it. But I do think overall, value-based care makes sense. Trying to keep people healthy makes way more sense than saying, I'm going to pay every time you get sick. There's not an incentive that anyone can get behind that says, yes, when you get sick, I'll take care of you. We all want to keep people healthy. That's why it's healthcare.
Thanks, Andrea. Scott, anything you'd add?
No, I think Andrea summed it up very well. We don't have all the answers. It's hard to believe that value-based care will somehow just go away. And so it's I don't think this is a reason to not get started.
Yeah, I think I would expand on that to say, just looking at a lot of my time, as some of you may know, is spent working with Congress and dealing with politics, which I both love and sometimes despise. But the reality is, I think the framework, or the agency may change, but the underlying intent and the commitment to what is intended, that will not. And if you think about the present administration, you think about Congress right now, it has everything to do with savings. It has everything to do with data and outcomes. And so that's really what this is. And so again, I think Andrea is correct that I think there are some answers and some questions that we don't yet have the answers, but fundamentally, I don't think that any of this is going to go away. I think it may just take some time and take maybe a different shape. But I will just say too, one of the other things that I really appreciate about on Belay and the team in general is that it's not pushy. It's sort of, so I've had the privilege of connecting Scott and Andrea and Brittany and others on the On Belay team with a lot of different health centers the last couple of years, sometimes just informationally. I think because many of you have arrangements already and some of them are working great. Just to be totally blunt, some of them are great. But I do think the value in having conversations with the On Belay team is just to evaluate and see what options exist, and to be able to just observe, okay, like what is going to be the best path forward. And I know these guys from a couple of years of experience, just watching the way they interact with health centers, and then hearing from health center members back after they've decided to start working with On Belay, that it's just a really fantastic rapport and understanding and partnership around what is really the mutual goal of what is trying to be achieved. So just to plug that, there's no obligation in having a conversation, but if you haven't had a chance to connect with the On Belay team, I would strongly, strongly recommend it, just again, to sort of orient to what they do and to see if it can be helpful to you and your health center. So quick flag again, if you have questions, you can go ahead and put them in the chat. We do have a couple of others. So not sure which of you might like to respond to this, but can you just go into and kind of highlight again the specific requirements or considerations for value-based care for FQHC settings in particular?
Andrew, I'm gonna let you try, or take a stab at that first. I mean, I'll also just say, since Andrea is new to On Belay, we're working with quite a few community health centers, and we have health centers in REACH. We have health centers in MSSP, and I think we have one health center in Flex. I'd have to double check that, but I'm not sure that there are overriding reasons why one program is better for a health center than another program. We do an analysis ahead of time using actuaries and other sources of information to figure out what's the best plan for each health center. And then Andrea, I'm sure you have some other things to say as well.
Yeah, so I think FQHCs actually do well in these programs Partly because they have support systems in place, right? So many have social workers and community health workers and just a team that's there to support their patients. So they're already doing a lot of things that are value-based care. I do agree with Scott. I can't say that MSSP Track A or ACO Reach is a better program for them because it really depends on every practice. The one thing I will note is that for an FQHC, attribution is always into any one of these programs is always going to be at the 10 level. So all providers who bill at that under the FQHC contribute to the attribution. That would be part of the program. But what we find in historically in my work with FQHC is we try to find ways to supplement the work that the FQHC is already doing. So if the FQHC already has great community health workers who are working with all their patients, for me it's, can I help provide chronic care management for a certain disease if that's not something they're doing? How can we support around the work that's already helping that FQHC? Because they often have a lot of systems in place. Maybe it's in providing better risk score coding. Maybe it's in inputting something into helping with their quality metrics, doing outreach calls, and really looking to see how do we work with that practice to highlight what they're doing and to supplement where they're not.
So Andrea, you flagged something that I hear a lot from the health centers that you've connected with through ACU and just otherwise, and that is to say there is such a healthy respect, and something that I think differentiates on Belay a little bit. There's a healthy respect and appreciation for the culture of the health center, and exactly what you just said, which is like, what are you guys doing really, really well already? We don't want to change that.
Yeah.
But where do you need help? And then how can On Belay provide the resources and in some cases the investment to be able to do that? But that, to me, that particular piece is really important because I think health centers are different. It's a little corny to say like, oh, they're magical unicorns, but they are. And I think that that's one of the biggest challenges and sometimes turnoffs that I see in this space is sort of, even when others have really good intentions, not sort of understanding the ethos of the organization and the culture. And then everything just kind of falls apart, or it doesn't have a path forward. So I appreciate you bringing that up because I think as folks are trying to navigate and consider kind of where they go and what they do next, that to me is really important. And from a partnership perspective, like ACU is pretty choosy about who we work with. So that's a big one. I think we've got time for one other question. I wanted to ask, or one of the questions that came in was around staffing requirements for an advanced primary care model. And if you guys could speak to that a little bit.
I can take a stab at it, and I'm sure Andrea will have other things to add. As I think we noted that Andrea is fairly new to On Belay, but I'm already learning so much from her. So it's just really been a real pleasure for me. Part of the last answer is relevant here. It's sort of like no one size fits all. So, when we evaluate any health center or other practice, as Andrew was saying, like we do an assessment. Where are you strong? Where are you not? Where do you need help? Some health centers, many health centers, have a pretty strong and robust, sort of care management team, and others don't. I mean, we work with some small health centers that aren't doing a lot of care management. So in some cases, we augment financially the care management team that's already happening. In other cases, we actually employ directly team members who work on site at the health center, but who are adding to the capabilities. Yeah, again, I think the key thing is it's not one size fits all. And as Andrew went through the timeline earlier, practices have to sign up by August 1st, and then there's a sort of drop deadline by early September. The performance year, the first year doesn't start until January 1st, and so we use that time as part of that assessment. Like, where are you? Where can we help? What do we not want to mess up? We don't want to mess with success. And Andrea, let me see if you have other thoughts.
Yeah, there is not one size fits all. You don't have to have your own case manager. You don't have to have your own social worker. We've had practices as small as, one physician and one NP who've done great in the program. And practices as large as, 50 doctors with specialists and a handful of case managers and social workers. It truly does vary. That's what we do as an enablement company, is work with what you have and support you in a way to make it successful. Every practice is going to have different capabilities. That's why I really like to start conversations early to say, let's look at your practice. Let's figure out how we support you in the best way to make sure that you're pulling all the levers that are in value-based care. But there are no requirements as to a minimum or maximum that you have to enter a value-based care contract.
That's super helpful.
Amanda, sorry for interrupting. There's one thing we haven't touched on, which I think is just really critical to make clear, because we've talked about risk. We've talked about there's upside and downside risk. The vast majority of organizations we work with, and I think this is especially true for community health centers, which have is a public trust that you will keep going. We take all the downside risk. So, our commitment to each health center and each practice is that financially, you will do no worse than what you would have done in fee for service. Our goal is to help you do much, much better financially and provide better care. But on Belay, because we work with so many, practices and now, tens of thousands of patients, we can take that financial risk because stuff happens, and we work with some small and large organizations. Statistically, despite everyone's best efforts, you can have, catastrophes happen to enough patients where financially you're losing money. We take all the downside risks. I just want to make that clear.
No, I think it's a good flag, Scott. And again, I will just acknowledge for everybody on the call today. Crazy to believe 2025 is my 20th year working with health centers. I still kind of refuse to think that I've been doing anything for 20 years, but yes, I have been doing it for 20 years. And I've never seen it the way that it is in all the years. And what I mean by that is I've never seen the simultaneous number of challenges and kind of fires, and the financial challenges just in terms of sustainability and unpredictability and erosion of 340B, all of the different things that I know you guys are coping with every day. So Scott is right to bring that up, that, this is not a time where most organizations have additional resources to be able, as much as it may make sense and as much as there might be the desire, there's just a lack of resources. So I am glad that you brought that up. The other thing that I would say, and again, just sort of reflecting back on the last couple of years working with Belay and sort of some of the health centers that they've connected with, it differs for every single organization. So this is not carte blanche, but what I will say is, just in doing the analysis of, hey, what might this look like with REACH, or what might this look like with MSSP, or any of the options, it's usually to the tune of several $100,000 and sometimes in the millions in savings. And so I look at that, and to me, it's like, well, there is no more vital time to keep those resources in-house and to do the efficiency and the optimization with a partner who is, one, going to bear the risk, but also honors the organization in the way that we've been talking about. So again, I would just, if you guys have not, for those of you on the call today, if you haven't had a chance to connect with these guys, I would really encourage you to do so. If you have questions about value-based care and contracting, please don't be shy to reach out to ACU, of course, also to Belay. If we don't have the answers, then we'll pull in the experts who do. But really, this is about helping and supporting everyone in the field. And so for that matter, if there are other topics or areas in this space that you'd like to lean into and learn more, also very much welcome that feedback. And including like what's working for you, like we also want to be able to share best practices. So we're just about at time. And so with that, we'll just say thank you guys so much, Scott and Andrea, for joining us today. Thank you, everybody who joined us for the webinar live. I'm just really grateful for the time at a moment when I know it's very, very busy. I will make a plug. If you haven't put on your grassroots advocacy hat this week yet, please reach out and contact your member of Congress and tell them to make sure that they extend funding at the highest possible level of funding for health centers before the deadline, which is Friday. But again, just a big thanks for all of the great work that everybody on the line is doing, to Belay for all of the great partnership, and we look forward to continuing the conversation. So have a great day, everybody. Thank you.
Thanks so much, everyone. Thanks, Amanda.
Thanks.
Thank you,
Take
everyone.
care.